Hello, and welcome to this satellite session titled Differentiated Service Delivery in 2020, Responding to the Needs of People Living with HIV Before, During, and After COVID-19. On behalf of the DSD initiative at the International AIDS Society, we'd like to warmly welcome you to the session. My name is Dr. Anna Grimsrud, and together with my co-chair, Lynn Wilkinson, we're really glad that you've joined us. So the session today is going to feature a series of pre-recorded presentations. Just trying to advance my slide, there we go. And these are really going to spotlight how differentiated service delivery has been responding to the needs of people living with HIV, both before COVID-19, now during the epidemic, and also how this is going to impact services going forward. You're first going to hear an introduction from me, and then examples from Kenya, South Africa, and Sierra Leone. The speakers include representatives from ministries of health, from national networks of people living with HIV, and from implementing partners. After these case studies, Lynn will share some reflections on learning from and beyond COVID-19 for DSD. Then we're going to have a moderated discussion with some reflections from this esteemed group of panelists. All of them have been long-standing advocates for differentiated service delivery and bring a rich set of expertise to the conversation. We are grateful to be joined by Chris Okolo, the Technical Director of the Linkages Program with FHI 360 based in Washington, D.C., by Dr. Meg Doherty, the Director of Global HIV, Hepatitis, and STI Programs at the World Health Organization in Geneva, Switzerland, Christophos Maloris, who is the Senior Advisor, Community Support with UNAIDS in their regional support team in Eastern and Southern Africa based in Johannesburg, Hannah Marquesi, who is the Health Economics Technical Advisor at USAID, and Lillian Mareko, the Executive Director of the International Community of Women Living with HIV in Eastern Africa, joining us from Kampala, Uganda. So I hope now that you'll sit back and enjoy the pre-recorded content, and we really hope that you'll also start to chat with us through the feature in the top right-hand corner of your screen. And we hope that you'll be part of our moderated discussion with these people at the end of the pre-recorded content. Thanks very much and enjoy the session.
Hello and welcome to this satellite session on differentiated service delivery in 2020, responding to the needs of people living with HIV before, during, and after COVID-19. I'm Dr. Anna Grimsrud from the International AIDS Society, and I'm going to be providing a brief introduction to the session today. Since 2016, the WHO has endorsed differentiated service delivery as an approach to providing prevention, care, treatment, and support to people living with and affected by HIV. Differentiated service delivery, or DSD for short, represents a shift away from a one-size-fits-all approach and recognizes that the needs and expectations of people living with HIV are different and change over time. It focuses on adapting the building blocks of service delivery, or the who, what, where, and when, to provide client-centered care that also reduces any unnecessary burdens on the healthcare system. First, I'd like to provide a brief update on progress towards scaling up DSD in sub-Saharan Africa before COVID-19. In 2019, countries in the region, and in West and Central Africa in particular, accelerated access to DSD by adopting national policies and guidance and moving from pilots to broader implementation. There was also growing recognition that people living with HIV require more health services and may have other needs beyond HIV. And so DSD models began to consider how to provide TB preventive therapy, as well as how they could be leveraged to support and strengthen family planning care. As countries implemented DSD at scale, eligibility criteria was reconsidered and often expanded to include more clients, as well as clients earlier after treatment initiation. Further, there was a renewed emphasis on the need for younger clients, children and adolescents, to benefit from DSD, including through a family-based approach. Support from global agencies continued, with guidance from WHO complemented by support from PEPFAR and also from the Global Fund, who acknowledged DSD as one of their 5 key investment principles in their HIV information note. The advent of COVID-19 has brought challenges and opportunities for DSD for people living with HIV and vulnerable to HIV, and in many instances, DSD has been thrust into the spotlight. While COVID-19 may be unprecedented, it is not unprecedented for DSD to support people living with HIV during emergency contexts. Sierra Leone and Guinea adapted services in response to Ebola, and Mozambique and the Central African Republic have adapted DSD during periods of armed conflict. The time is now to leverage and to adapt DSD in response to COVID-19, and many countries have done this, and this is going to be the focus of the session today. It's critical to limit exposure and ensure ongoing treatment and support by, first of all, adapting the frequency of clinic visits by reducing them as much as possible, and secondly, by enabling ART refills outside of health facilities. To reduce health facility attendance, we can expand access to DSD, expediting all clinically stable patients into out-of-facility models and ensuring more people are eligible by adapting the criteria for eligibility and increasing the duration of ART refills and scripts. Both facility and community-based models should support physical distancing through extending and staggering collection times and expanding the number of collection points. Wherever possible, the duration and number of providers seen should also be minimized. DSD is so much more than 6-month dispensing, and our lineup of brilliant presenters today from Kenya, South Africa, and Sierra Leone are going to be able to share their experience on DSD before and during COVID-19. Finally, we'll close with a brief presentation from my colleague Lynn Wilkinson on where to from here, learning from and beyond COVID-19 for DSD. Thank you very much. And with that, I hand over to Dr. Ngugi from the National AIDS and STI Control Program and the Ministry of Health in Kenya.
I'm going to present on Kenya's HIV program in regarding to differentiated service delivery before and during COVID-19. A bit of background, but what my presentation has more information and it will be available, so one can refer to it after. Total population in Kenya, we have around 47 million. People living with HIV, we have around 1.4 million, with around 1 million already on treatment. And our prevalence in Kenya is 4.4%. The slide on the picture on the side showing Kenya in terms of distribution of HIV prevalence, with more data showing a higher prevalence of HIV. This is our Kenya DST journey. It started around 2016, where that's the time we included DST in our IRT guidelines, recognizing of with recognition of patient-centered models. And then around 2017, we scaled up around 10%. To ensure that 10% of our eligible patients are able to pick up their drugs with the fast track facility models. In 2018, we scaled up to around 20%, now moving further to community and expanding more to other different populations, especially adolescents, children, and unstable clients, which were not there in 2016 and 2017. In 2019, we have scaled up at least to 60% of eligible patients. We are now around 350,000 for different forms of DST model, majority being on multi-month dispensing. And as well as now we are considering as well a review of to other populations, especially key, and review of M&E systems and private sector engagement framework for ART. The different models have stable clients at the facility level, at the community level, and population-specific models as shown within this slide. What is as well, in addition, not only for stable, but even unstable, we have viremia clinics where clients are able to have psychosocial support within the facilities. But you can see that we have other models that have really, especially male ART adherence clinics and the wicked clinics for adolescents. In other areas, they call it teen clinics. How have we adapted so far during COVID-19? We released our guidance, and this time we ensured that to ensure that we minimize disruption of HIV and STI services, and as well have decongestion of facilities and minimize the risk of COVID-19, especially to our clients who are living with HIV. We released a guidance where we had our clients who are eligible for 3 multi-month dispensing beyond the stable clients were given the drugs. And this time we ensured that our health facilities within the counties received more than 3 months stocks. And they had, especially during March, we gave them 4 months. Now, this was informed by definitely the commodities at the health facilities, as well as during national warehouses, and ensure we cross-checked how our pipeline is regarding to supplies. And this slide shows how we have been able to trend between January to May, and you can see the spike March when we gave out that guidance. And this slide shows more of how that picture, how communities are picking up their drugs. Beyond the ART, there's TPT, Septrin, and oral contraceptives. And then we still have some other counties doing home distribution of the ART for clients unable to access facilities, especially where counties we have lockdown. And you can see, like, for example, you have a picture on the side there where Nairobi, which is a city in Kenya, is a bit locked. And a policeman there which is guarding the border between two counties to ensure that the epicenter counties with COVID do not, those are the government directives that have been given, elected police roadblocks. Additional practices, what we are doing in Kenya is we have scaled up HIV self-testing services, ensuring that as well we strengthen interfacility linkages to enable access of ART, and well adapting other models, especially for key populations, especially those who are picking methadone, that we have used mobile vans, and as well using a virtual platform called Ushauri to reach out to our clients, that they can call us and we can call them to remind them of the clinics, and in case of they have any issues, then we can be able to alert them and guide them on what to do next. So far, so good, but lessons learned so far is we want to ensure that we have monitoring and evaluation tools is it's still an issue for us, and we need to sustain momentum of DSD and then further scale up of models beyond COVID-19, and as well review the guidance that we gave around in March. And as well, we do, monitoring further beyond the ART distribution, but monitoring family planning and treatment for other non-communicable diseases. Thank you.
My name is Dr. Paul Wekesa. I'm based in Kenya. I work for Center for Health Solutions, a local organization based in Kenya. And I'm going to share our experience scaling up differentiated service delivery models, especially during this COVID-19 period in Kenya. Next. So Kenya began implementing DSD models in 2017 and are now an integral part of the HIV response. And majority of patients have been opted into whether facility-based or community-based models. And as you can see on the right side of the slide, some of the models that have been adopted in Kenya at facility and community level. And for implementing partners such as ourselves, we had really had a scale up of patients, especially stable patients, being enrolled in DSD models. 91% of our patients in the project that I'm presenting in Siaya County in Kenya were already on a DSD model by March of 2020. 69% of these being ART group type models. Next. So this slide is an interesting slide, and it shows you the scale-up approach. Since October 2017, when we began implementation, there was a steady increase in our enrollments into DSD models. Of course, this slowed down in September 2018 because of DTG optimization, which was done as a rapid initiative countrywide. But thereafter, from December 2018, you see a steady growth in the numbers enrolled at either community or facility DSD models. And what's important also is what happened in the period beginning March. Kenya diagnosed the first case of COVID in March of 2020. But you can see since then, there has still been a steady increase in the number of patients enrolled into a DSD approach, just because of changing of the criteria, eligibility criteria, focused on reducing frequency of visits, and allowing longer prescriptions and the longer refills of medications. And these have been important to shorten the visit periods and visit times at health facilities. Next. So multi-month dispensing is another important component, and we've had this now opened up to all patient groups, whether a patient is stable or those who are previously classified, who would be classified as unstable. So you see that this graph shows that increment in DSD patients and others who are receiving multi-month dispensing because of COVID-19. And that really began in March of 2020, since the first case was diagnosed. Next. So we are continuing to monitor clinically all the patients who are on a DSD model, especially those who would have been classified as unstable and are now offered a DSD approach post-COVID, and define models. How would we, properly implement DSD for unstable clients in order to improve their outcomes and their retention on treatment? Also, scale up of ART groups beyond, for specific populations, including men only groups, adolescent groups, just, recognizing the differences that each of these patient population groups would have and in the implementation of the approach. And also just understanding the cost, with the scale up, what are the cost implications for sustainability, for planning, for policy development, for service delivery, transition. All of these become important for programs to understand, the impact of this approach. And of course, to analyze these outcomes before and post-COVID. Next. So this is just a few pictures to show some of the differences. You see that in the pictures above, the two pictures above, a bit of protection with the masks on and a bit of physical distancing, unlike before, where community groups would meet, openly and without the measures that are now important with the COVID pandemic. Next. Yep.
Good day. My name is Beth Harley and I'm a medical officer and I provide HAST program support for the City of Cape Town. I'm going to be speaking to you about 10 years experience of art clubs. So I work in the Cape Town Metro Health District, which is divided into 8 sub-districts, and it serves a rapidly growing population of 4.6 million with enormous socio-economic diversity across sub-districts. In fact, the South African Gini coefficient is the highest in the world. City Health provides care for more than 75,000 patients on art, more than 33,000 of those in clubs. There are 70 city facilities that provide art care, and 47 of them also provide club care. And these graphs illustrate the enormous range of the sizes of the services offered, and this makes providing program support more complex. Club care was unrolled in 2011, 7 years after art services started. And at that point in time, for City Health Services, there were 21 facilities providing art for fewer than 20,000 patients. However, at the time, increasing congestion was resulting in increasing loss of patients and also increasing delays in starting new patients on art. So in 2011, there was a rollout of the club care over a 3-year period. This was a collaborative project between MSF, who provided the club model, IHI, who provided the rollout model, and the 2 primary healthcare service providers, the Metro Health Services and City Health. And I was the club mentor for the City Health facilities from the start of the program, and that remains part of my portfolio. After 3 years of rollout, it was clear that club care was not producing the promised decongestion. So we instituted quarterly meetings for club staff, where we really challenged them to grow their clubs, which had the desired result. However, with growth came an increased club workload, and with the increased club workload, emotionally staff began to feel that clubs were creating work rather than saving work. So City instituted a new club model to try and smooth the workload of clubs, which resulted in further growth. In the new club model, club days were introduced where the nurse could be allocated for the whole day to club care. In the morning, she could see patients for either a blood or a clinical visit and have the rest of the day to devote to club systems. Sadly, there was a bit of loss in our gains with the introduction of a CDU capping system. And this just demonstrates that club care falls within a much greater health system, and sometimes decisions that are taken can impact on club care. But in 2018, City Health did their first round of audits through all the sub-districts for club care, and not surprisingly, we discovered a number of gaps in care. At this point, there were 37 facilities providing art club care, and we set up a City Health Club champion group to try and address the gaps in care. But the group was set up not just to close gaps in club care. We also very deliberately tried to grow people and develop a dynamic team to maximize the effectiveness of the group. And by the end of 2019, we had a long list of successes. However, the obstacles we faced were around the fact that club care sits in a greater system. And we found that we couldn't just directly speak to staff about club care issues without understanding their lived experience of the bigger systems and take on an advocacy role around some of the system issues that were impacting on their being able to provide club care. From there, I'm just going to take a side step to show you an unintended test we had of the robustness of club care systems last year. Our largest facility was closed for 7 months after a fire, and the graph illustrates the enormous loss to care that we had. But whilst 56% of the in-facility patients were lost, only 8% of the club patients were lost. And this really demonstrates that within a crisis situation, club care really is part of the solution. And I've been hearing similar stories with the short-term facility closures we've been having around the COVID-19 pandemic recently. So what are we doing around COVID-19? When I was asked to put together guidelines, it became very clear to me that club care already looks at maximizing efficiencies and therefore was already part of the solution in dealing with COVID-19. Of the new possibilities, the most exciting has been a system put in place by province that allows for the home delivery of patient medication parcels for those on chronic treatment. However, ironically, because club care systems work, facilities do not see club patients as a priority and have mostly used this system for the NCD patients because congestion at pharmacies is more of a challenge. So what comes next once the immediate crisis of COVID-19 is over? Well, we're already doing good work, and we will continue to do the same good work, and it will continue to bear fruit. One area that would make an enormous difference to club efficiencies at the stroke of a pen would be annual scripting being made available. And many thanks to those who continue to advocate for that. Otherwise, we're exploring effective meeting spaces in the time of social distancing. We intend to look at producing short videos to support the implementation of club care systems. And this has really been inspired by this virtual conference. And then the further use of technology to improve efficiencies. Once medication supplies have stabilized, we also want to explore the possibility of 6-month clubs. So what are the take-home messages after 10 years? And I find it is just so important to keep reminding managers and staff of the following points. Club care continues to be part of the solution. And after nearly 10 years, we find that there is so much potential that is still to be tapped. Optimizing club care systems is an iterative, continuous cycle of meeting obstacles, finding solutions, and maintaining systems. You never arrive, and I find managers and staff are very quick to want to just click the club care box as if it were done. Thirdly, club care falls within bigger systems, and it may be necessary to take on an advocacy role for issues outside of club care that impact on club care. And lastly, People remain the most valuable resource in terms of optimizing club systems. Time is needed to work and grow people. And at the start of the program, I sort of naively thought that the club systems spoke for themselves in terms of the efficiencies that they provide. But I've discovered that staff can feel emotionally very different about that. And that we really need to meet as people, with people, if we wish to unravel the enormously complex experiences people have and tap into the full human resource potential. So I invite the DSD community to adopt the African concept of Ubuntu, which is often loosely translated as I am because we are. And this speaks to our interconnectedness and our shared humanity. So let us be fully human together. Thank you very much.
Hello everyone, I'm Idris Sadiem Songo. I'm presenting on behalf of the Network of HIV Positives in Sierra Leone. Next, please. Yeah, for the impact of COVID-19 on DSD in Sierra Leone, we'll be looking at both the positive and the negative. So for the positive, we have been able to establish functional community ART groups, and this had actually led to increased uptake and adherence, thus contributing to reduction in defaulting. This has also contributed to allow communities to be able to reach harder to reach people because they all live in the same community, and it has also improved early detection and quick response. All recipients of care now receive 3 months drug distribution. Now for the negative impact, evidence from our community-led monitoring has shown that because people are now receiving 3 months drugs, if adequate preparation is not done, this could lead to drug stockout. Many recipients of care fear visiting health facilities because they perceive health facilities to be fertile ground for COVID-19 infection. As a result of COVID-19, some essential services like viral load and early infant diagnosis testings have been suspended. Also, there is shortage of second-line treatment and pediatric ARV. Because of a total lockdown and because some PLHIVs do not have adequate food, this has led to this has negatively affected uptake of ARVs. Next slide, please. Now for community adherence groups, we want to look at the key principles we're operating in Sierra Leone. The membership of this group range between 6 to 10, and for you to be a member of the CAG, you have to be a stable recipient of care, and you must be on treatment, and you must reside within the same geographic location. Group members perform community-based delivery of medication, provide adherence support, and monitor treatment outcomes. And they do this with support from the National AIDS Control Program. One member of the group actually collects medication on behalf of the other members, and they do this by turn. They also provide peer support during drug distribution and also promote treatment adherence among peers. One interesting thing that we need to note is the fact that community ART groups serve as link between the communities and healthcare settings. And they also raise awareness on COVID-19, especially when it has to do with infection prevention and control measures. Next slide, please. Next slide, please. Now the photo that you see, this is just a photo for our meetings that we conduct during community adherence group. And the first one on the right, on the left, the top on the right, left, and the one on the right, these are the group meetings. And the one at the bottom was when we call at the start of COVID-19, when we call key population members to see how we can all plan together to implement COVID-19 activities. Next slide, please. Now, where do we want to go from here? We really want the NACP to take lead in coordinating the implementation of DSD in Sierra Leone as per the policy. And in doing this, we really want to see that communities are fully involved in the rollout and implementation of these activities. And also, drop-in centers or wellness centers that are managed by key populations and natives must be equipped and empowered to carry out essential HIV services in order to decongest the health facilities. We really are looking at two prioritized studies. One of those studies is that we really want to look at the prevalence of HIV and COVID-19 comorbidity. We also want to understand the effect of COVID-19 on adherence to ART. Thank you so much for your attention.
Hello, everyone. I'm Dr. Aaron Vandi, National ART Coordinator, Ministry of Health and Sanitation, Sierra Leone. Today, I'll be presenting on prioritized DSD implementation in Sierra Leone due to COVID-19. Next slide, please. In 2017, we developed DSD guidelines, but however, due to some challenges, we were unable to implement DSD in the country. In 2018, with the support from our implementing partners, we were able to review these guidelines and also plan to standardize DSD practice in the country. However, during this planning, the COVID-19 pandemic happened, and during this time, we decided to fast-track implementation of DSD in the country. And also, we decided to review the eligibility criteria for all models as a way to reduce clinic attendance during this time. Next slide, please. In Sierra Leone, currently, we have two DSD models. We have a facility model and the community and group models. So for the community group or group models, we have a very good network of HIV positives in the country, and we use this medium, the support group they have, to deliver ARVs. And we also have home delivery of ARVs and drop-in centers for key population. So all of these are areas where we do ART refills in the community. And for the facility model, all recipients of care, regardless of whether you're pregnant, you're a child, or TB and HIV co-infected, are given 3 MMD during this period. Next slide, please. One thing we found to be very useful during this period is multi-sectorial collaboration. And this includes our work with the district health management teams, our implementing partners, the network of HIV positive in Sierra Leone, and also the TB program. Currently, we're using the integrated community outreach program to provide ARVs for our recipients of care in the community, and not just HIV services, but also routine health services in the community. This has worked especially during the time or in an area where we're dealing with stigma and discrimination, because all the services are integrated and we're going to the community without anyone know what our agenda is. We also rely on our implementing partners for technical support. We've been able to review our guidelines during this process and also scale up on DSD services with HR and logistics support from them. Next slide, please. So this picture shows community and facility ART refills since the start of the COVID-19 pandemic to date. So as you can see, the community ART refills has been increasing, and it's more than compared to the facility models which we have currently in the country. And we plan to fast track and scale up on the services to ensure that we provide HIV services at the community. Next slide, please. So some of the best practices we realize is community ART distribution with support from our partner is very, very good, because we've been able to cover more people and also scale up on the services within a short period of time. And we're also supporting the COVID-19 national response to ensure that recipients of care are not neglected during this period. We also start using electronic data reporting tool for community ART distribution, which is very good for decision making. And we are updating and also giving contact numbers for recipients of care to call their healthcare providers for ART refills during the lockdown. Next slide, please. Some of the challenges we have is human resource especially for community ART distribution. We have limited data for decision making and also intermittent stock out of ARVs and also IPC material. However, during this period, some of the questions we have is during this period is the effects of COVID-19 on adherence to ART, what's the prevalence of HIV and COVID-19 comorbidities, and also management of cases for COVID-19 confirmed cases in people living with HIV. Next slide, please. My advice to everyone is to ensure that you have data for action, especially for policy making. Multi-sectoral collaboration is very important. Strengthen your supply chain to prevent stock out, and always ensure that all intervention are patient-centered and take context into consideration. Thank you for listening.
This is Lynn Wilkinson, reflecting on learning from and beyond COVID-19 for DSD. After those excellent and informative presentations, I will conclude by looking beyond the 3 countries you have heard from, attempting to succinctly summarize the categories of DSD adaptions and expansion made by countries in sub-Saharan Africa during the COVID pandemic, pulling out an example of each and then briefly reflecting on the key DSD lessons learned and critical focus areas to support continuation of expanded DSD, where it's safe to do so for people living with HIV. There are 5 broad categories of DSD expansion and adaptions made as reflected in the top row of this table. Firstly, expanded implementation of existing DSD guidance to increase the number of people living with HIV accessing DSD models. Here you will see Mozambique specifically expanded 3-month refills to all facilities, and as reflected in the line graph, increased enrollment in a single month by more than 10%. Secondly, countries reduced DSD eligibility criteria to increase the number of people living with HIV on ART being able to access DSD models. Zambia had already allowed 6-month refills for stable ART patients, but also allowed people newly initiating on dolutegravir regimens to be dispensed with 6 months of ART from ART start. Thirdly, countries increased ART refill length. Malawi specifically changed from 3 to 6-month refills for all stable patients on treatment from 3 months, other than pregnant women who qualified for only 3-month refills. Fourthly, countries increased script length, thereby reducing the frequency of required clinical consultation. South Africa, as a temporary measure, has allowed existing 6-month scripts to be valid for 12 and new scripts prescribing for a period of 12 months. Patients therefore only need an annual clinical consultation for their rescript. Fifthly, countries have been conservative in the past with allowing access to DSD models for specific populations and have now allowed this during COVID pandemic. Ethiopia, which previously implemented 6-month refills for stable adults, allowed children, adolescents, pregnant and breastfeeding women, and people with high viral loads to access 3-month refills. Zambia very encouragingly expanded its existing 6-month refills to adults for adolescents 10 to 19 years of age. Lastly, countries expanded community models of care quickly and adapted facility and community models. Expansion of community models was seen as critical to ensure wide access to ART refills close to home. Uganda quickly set up more community dispensing points and their version of community ART groups. Eswatini extended the hours of their facility-based DSD models to reduce the number of people attending a clinic at any one time. In summary, we have learned that DSD models provide us with a capacity to adapt to the changing needs of people living with HIV quickly. Scaled DSD implementation introduces more flexibility and less reliance by people living with HIV on health facilities. This is important not only during health system emergencies, but the emergencies that impact many people's daily lives. Community-based model options remain critical. Treatment close to home. As we move towards 6-month refills, we need to ensure that we do not end the need for community models, making them unavailable when they are needed during times of health system crisis. We now know that longer ART refills can be considered earlier after initiation and can be considered for specific populations. Clinical consultations could be reduced with longer scripts allowed. And lastly, group DSD models can provide a longer ART refill without dropping peer support, which can now continue virtually. What we need to do to ensure the lessons learned from COVID-19 are not lost is now critical to monitor and evaluate outcomes of patients accessing DSD models compared with routine care during COVID-19 pandemic, similar to what Dr. Beth Harley showed when the fire burned down a busy clinic. This includes earlier access to DSD and specific population access to understand the risks and benefits for these people. Qualitative research is required to explore patient perspectives on expanded access, how this actually impacts our lives. This will allow us to determine which expanded DSD eligibility criteria, increased DSD access, and DSD model adaptions can be continued safely beyond the COVID-19 pandemic.
And welcome back to our live session. We're now turning over to our moderated discussion. Anna already kindly introduced our panelists who are now on your screen before you. And I'm going to start that moderated discussion by asking each of our panelists a specific question. I ask that you keep your answers down to 2 minutes if possible to provide our audience with an opportunity to also ask some questions. So over to Meg from WHO. If you could just let us know what you think the positive advances have been for differentiated service delivery during the COVID pandemic, and which of those gains should be focused on beyond COVID.
Thank you very much, and I'm so pleased that I can be here with you today, because you all know that differentiated models or differentiated service delivery is one of my favorite topics, and certainly we're very supportive of this work from the WHO. We have undertaken, like many different organizations, and we've heard some excellent models and examples coming from your presentations today. We too have undertaken a survey to understand what are the risks to either stockouts and how are countries mitigating these effects during the time of COVID. And we can see that, like you've shown, many of the countries have already adopted a multi-month dispensing and or DSD models, and they're beyond just multi-month dispensing in terms of community delivery, etc. But that because of the risk of potential stockouts, where we have about 24 countries that have a severe less than 3-month risk of not being able to keep their supplies in order for antiretrovirals, that some of the countries are having to move back to fewer months dispensing. So there are some great positives and gains in terms of policy shifts, but we have to be on top of this stock in the supply chain to ensure that countries can actually fulfill these longer prescriptions. But I think some of the other positives that we've seen in this survey is this multi-month dispensing and community dispensing and community network of support during this time has extended beyond HIV. We see it now for the DAAs, or the direct-acting antivirals for hepatitis, in many of the countries in what we call the Southeast Asia and Western Pacific regions. We've seen it actually expanding into OST, or to the drugs that are used for opiate substitution therapy, which is an enormous step forward, that people who use methadone or buprenorphine are able to take these medicines home with them, and that's for HIV care. And we've seen it for hepatitis B drugs, and also for some of the tuberculosis and the prophylaxis drugs. So I think that sort of was simply put, you know, during the time of this pandemic, there has been great innovations for other diseases as well, learning from the HIV experience. And I agree with you all, it's not just about multi-month dispensing, but it's about the service delivery and using peers and using models where people, it's closer to home, person-centric, person-designed, and not so much linked to and requiring the facility. So I think we have to keep an eye on this as we move forward and ensure that we can take some of these innovations that are happening in Pakistan and India and other places around the world and make sure that they happen in all settings for hepatitis, for OST, for harm reduction, and for TB. Thank you.
Thanks, Meg. I think that provides a nice segue to our next question to Chris Maloris from UNAIDS. As Meg said, I think many of us see DSD as going beyond 6-month refills. What would your definition of DSD be?
Thank you, Lynn. I guess our definition, or my definition on DSD, goes beyond just the medication, the number of pills that people get when they arrive at the clinic. It provides a way for a new way of empowering people living with HIV to not feel trapped and hostage to how much medication will they take, going back and forth to the clinic. It really allows people to start feeling a little bit more normal. We've been trying to say that living with HIV is like a chronic disease. Let's make it more. Let's really use the opportunity to allow people to feel free. It also changes the dynamics with the health providers. It provides a different relationship. And this has become really crucial during COVID, when people couldn't access going to the clinic because transportation was not available. And so impromptu types of ARV groups were formed. And when people arrive at the clinic, they're not met with, yeah, but you're not the agreed group, but rather a trust that allows the medication to go to communities. It also supports the changing the mind in terms of, it's not just about what happens at the clinic, it's getting to the clinic. That is, how are people accessing it? How far is it? Can women leave the home? Can men that are in informal working conditions take time off work? And once they arrive at the clinic, what happens there? What's the relationship? And then you have to go back. All of that allows us to think of a person living with HIV not in terms of just their viral load and how stable or unstable they are. It's about being a human being that needs a treatment with as few barriers as possible. And COVID, again, as Meg started mentioning it's a learning opportunity for all of us. We've seen from one point of view how fragile some of these community groups are. When something unexpected hits them, they don't have essential workers license, for example, in order to be able to move around the country during lockdowns. How do we go about it? The system is not strong enough to allow for, let's say, breakdown in transportation and so on. But at the same time, it has shown how, because trust has been built, we can adapt, we can move quickly and provide services. So for me, the way forward is more about how do we share this? How do we expand? How do we make it more resilient? But also, how do we use it for other treatments? It doesn't have to be about ARVs. How do we just break the myth or release people from being held hostage to how they access pills? Thank you.
Thanks, Chris. And that takes us on to a question for Lillian from the International Community of Women Living with HIV in East Africa. When we move beyond only art and how we can leverage differentiated art delivery to be able to scale up family planning access. As we know, or if you don't know, the International AIDS Society has launched a supplement specifically on this subject. And if you look in the chat and in your briefcase, you should find the supplement. But Lillian, please, if you would just tell us how you think we can leverage the lessons we've learned from DSD for family planning.
Thank you very much. It is important to note the contribution of DSD within the HIV service delivery, that the most important is that it places the recipient of care at the center. It looks at this individual from a comprehensive point of view and takes their needs and priorities at the center in a way that and like we've heard from Anna, that it is not one size fits all. And therefore, we have to look at that. And as we look at family planning and also access to sexual reproductive health and rights, that is one important piece that we need to learn from DSD. But it is also important to understand that when you talk about differentiated service delivery, you're looking at providing an opportunity for an individual to exercise their human rights. And therefore, that is very, very important. But it is also important that when you talk about differentiated service delivery model, it contributes to reducing issues like stigma and discrimination, that you're having services and accessed by people in a mode that they are interested in and that they think is very safe for them. And also to mention that when you talk about DSD, especially, for example, where you're having a multi-month dispensing, you're reducing on this gender-based violence that women and girls probably are likely to face, to the extent that if one takes 6 months refill, and for family planning, for example, then they are reducing on the burden of being asked where you're going, where you're coming from, and therefore being exposed to gender-based violence. And therefore, family planning can learn from all this, but also importantly that people living with HIV and AIDS have been placed at the center of programming, policy development, implementation, and monitoring and evaluation. And that's what family planning can learn from this. And therefore, to conclude, probably to say that what we are learning here is the integrated service delivery model that looks at human rights, gender consideration, and therefore if family planning can learn from this, if we can learn to work with the women who are the beneficiaries of the services, we believe that service delivery would give us the best outcomes that are needed for family planning and generally sexual reproductive health and rights. Thank you.
Thanks, Lillian. Thanks so much for that reflection. I think we all hope that some of the lessons we've learned from not over-medicalizing care and the provision of treatment really plays a part in other treatment too. So over to Chris Akolo from the Linkages Project at FHI 360. Chris, we're going to put the same question to you, but really specifically relating to key populations. So what advances have you seen in DSD for key populations during the COVID pandemic? And what do you hope can be taken forward from those to continue past the pandemic?
All right, thank you very much for the opportunity to share some experiences and some lessons that we've learned from implementing key population program in multiple countries, particularly within the context of COVID. Something that is very important for us to take note of is that, within the context of COVID and the lessons we're learning, we're seeing opportunities for avoiding some of the barriers and for working against some of the barriers that are preventing key populations from accessing essential HIV prevention care and treatment services. And I'm going to just discuss briefly following that particular order, starting from prevention. We've seen across multiple countries that the COVID pandemic has provided an opportunity for countries to relax, some of their policies and some of the reasons why they were not very comfortable initially, to allow some measures, some activities to be implemented. For example, in the area of HIV self-testing, we're seeing countries now being a little bit more flexible in terms of allowing and making policies available to ensure that HIV self-testing kits are made available to key populations, particularly because people are no longer able to test using the traditional approaches. So I think that makes a lot of sense. The other thing we're learning, which we hope will continue, is under PrEP services. We're now beginning to see that countries are also very comfortable now issuing multi-month dispensing of PrEP medications to individuals who are on PrEP, and therefore allowing them to continue to take PrEP without having to come to facilities to take their PrEP medications. We're also seeing opportunities for multi-month supplies of commodities such as condoms and lubricants, including needles and syringes for particularly within NSP programs, multi-month supplies. And we need to just make sure that forecasting and quantification measures are put in place so that we don't run into stock out of these essential commodities. In the area of treatment, particularly to ensure retention and treatment, we're seeing countries relaxing their criteria for eligibility for multi-month dispensing, particularly 3 months and 6 months. We have actually seen a scale up of multi-month dispensing, particularly 3 months across multiple countries. We're also seeing home delivery of ARVs, and this is something that we're welcoming because we know that a number of key populations who are living with HIV continue to face stigma and discrimination within healthcare facilities. So being able to continue delivering ARVs within some of these community-based sites is very, very essential. The other thing we've actually learned from, particularly in the area of viral load monitoring, is community-based sample collection for viral load, particularly at drop-in centers. This is very, very essential, very, very important. And we've seen countries now relaxing some of the requirements for allowing some of the samples to be collected. And finally, that virtual engagement of key populations. A lot of key populations want to remain anonymous across the entire cascade as much as possible. So our ability to be able to help reach them online, provide some services online, and of course, connect them offline to uptake some of these very essential services is very, very important. And it's something we hope will continue and programs will continue to leverage on as we continue to implement some of our programs. But finally, making sure that countries put in place policies that will actually support the full and the scale up of all these measures is very, very essential. And we're looking forward to work with the countries to ensure that some of these policies are put in place and we can continue to implement programs for our key populations. Thank you.
Great, a really well, a good summary for all of us. And thank you for noting the point about the viral loads. I think we are seeing the use of viral loads differently, specifically triggering when actually a clinical visit is needed and otherwise potentially delayed. So thank you for highlighting that. So I'm going to move over to our last panelist, which is Hannah from USAID, and really here focusing on how we can support and accelerate access for people living with HIV to out-of-facility models, looking at where we can partner with communities and private partnerships to accelerate that momentum.
Great. Thanks, Lynn. So at USAID, in addition to many of the models that were mentioned today, we're also looking at a number of public-private partnerships to expand access in the private sector. And those include private clinics, which could be for-profit or nonprofit clinics, and working to make sure we can get either government or donor-supported commodities to flow to those clinics. We're also looking at private or community pharmacies and seeing how we can create partnerships between those pharmacies and public facilities, so pharmacies can serve as satellite refill sites for ARVs. And then there's a number of sort of out-of-facility community models that we're looking at, one of which is home delivery enabled by private sector groups, which could be partnerships with NGOs, with private pharmacies, or third-party logistics groups. We're also looking at community pickup outside of group models, so in particularly at schools and churches. And then the last one, which is probably the most innovative, is automated models, which has really been pioneered in South Africa through electronic lockers. So I think all of these models we've been interested in expanding because we know that, especially for certain populations, they prefer accessing care in the private sector. And that's especially true for urban groups, higher income groups, many key populations and men, especially in countries that have large participation by the private sector already for non-HIV services. So we're also looking to see how we can integrate HIV into existing non-HIV private healthcare systems. And especially in the COVID context, we're trying to see how we can leverage existing private sector infrastructure and health workforce to rapidly expand or maintain access, especially when other DSD models become more challenging to implement due to many of the supply chain issues we're seeing and challenges with meeting in groups. Thanks.
So thank you to Hannah, to the two Chris's, to Meg, to Lillian, to Lynn. I just want to say before we close that I think that you guys all did an excellent job in the discussion of really bringing up how we need to go beyond just longer ART refills, consider the multiple needs of people living with HIV, consider how this applies to PrEP, and ensure that we are pushing to support people to access care closer to home through all the innovations that can happen both through group and individual models of decentralization. So just to sign off here and make sure that we all know that in this rush to return to normal, we reconsider what parts of normal we're going to rush back to. But it's really nice to see you all again, and all the best for the rest of the conference. Thanks very much.